notes, and I went over them with Dr. Hoosby. Sorry, why is this? There we go. All right. I want to pull up your med list, which is why I wanted. But go ahead, tell me what you want to accomplish with this visit.
You know, it's not me, it's these two.
Okay, fine.
I was perfectly happy with everything.
Well,
that
actually,
happened.
I heard so I heard you kind of perking along.
Mm-hmm.
You had some things happen. Somebody put you on some meds. Maybe you felt worse. Dr. Hoosby did what I would have done, which is cut him down or stop him.
Right.
And you were feeling better. And is that where we're sitting right now?
Yeah.
Is that kind of a big, broad stroke?
Yeah. I was on the Toprol, and my blood pressure started to go down. And she took me off that, and I've been doing good. Dr. Crea put me on Credaville or something.
I'm going to look up.
Yeah. And just a very small dose, because my pulse has been really, really high. I mean, it's always like 113 or 1
I
something.
bet it wasn't when you were on the Toprol.
Yeah, what was it when I was on the Toprol?
No, it was 60, according to Dr. Hoosby anyway.
Yeah, I don't know. Anyway, it's now down to about 104 or something.
What's the one with your med list?
As far as the heart stuff right now, I'm feeling good about that. My rheumatoid arthritis, I'm in a really big flare right now.
Well, yeah, with all the med changes, I'm not
Oh my
surprised.
God, I'm just in a lot of pain. So I called my rheumatologist today, and I think he's gonna give me some more prednisone.
Carvedilol, is that the one you were trying to?
Yeah.
Yeah. And he's having me do my blood pressure twice a day, and if it's low enough, take it, and then in 2 weeks, which is another week, I have to go call his nurse and give her my blood pressure readings, and he wants to bump it up.
Okay, so Dr. Hoosby already did the big cleanup, so.
She did.
Yeah, we talked about that the day that she came in with the pile of papers this high of.
Yeah.
So what do you want to get out of this visit?
Well, I can tell you.
Okay, there we go.
Yeah, it's not me.
You know, we felt that we got really, really good care from each of the individual physicians. We felt like there were an awful lot of chiefs.
Indians, but not in.
There was a whole lot of Indians, but no chief.
Okay.
Who was in charge of the plan? We felt like each, you know, one doctor would prescribe one medication, and the other one would come in and say, "Whoa, what's going on? We can't do that."
Yeah.
And so it was a kind of coordination of information and lack of a plan of treatment, as
yeah.
opposed to each physician kind of operating on their own.
Yeah, so around here, Dr. Hoosby should be the chief, and there actually are, you caught us right on that. I've only been here for a few months, so I caught Billings on the cusp of a whole bunch of changes where things used to be able to happen in the hospital
Right.
that she wouldn't necessarily know about. And actually, between now and the 6th of May, a whole bunch of controls are being put in place that will keep that from happening. So, so for example, the whole business with the Toprol, and I went over that in great detail with her. The Toprol strategy would have been reasonable were it not for all the other things going
No
on.
kidding.
In which case, because it's probably it's kind of the standard thing, but given everything else that was going on, your small size, your other medical illnesses, one of the other medicines that you're on, you probably had a much bigger slug of Toprol than it seemed based on the doses of medication. I have to tell you, I did this at Mayo for 14 years, and I remember one of my medical students looking at me once and saying, you know, most doctors make people better by giving them medicines. You make them better by taking them away. And it's exactly what you're talking about here is there needs to be somebody looking down and looking at all the pieces, and that's her job, and that's what she wants to do. And this got done kind of before she had a chance to react to it. Once she saw what happened, she had a pretty good idea what needed to be done. She did it, and now you're feeling better. But that's, I wish I could say that that happens everywhere. I wish I could say it doesn't happen here. There's gonna be more controls to keep it from happening here soon. But that's the reason to keep the primary doctor in the loop all the time. So, you know, I always tell my patients, the ones I used to see every now and then at Mayo and the ones that were mine, you know, when you get out of the hospital, first thing you should do is take your dismissal summary to your doctor and make sure that there isn't something that this doctor that took care of you in the hospital didn't know about when they wrote for the medicine. It's interesting also, the old brand name of Lopressor, the old brand of Toprol was called Lopressor. It was and the nickname of most doctors was No-Pressor, because it was such a lousy blood pressure medicine. It didn't really lower blood pressure very well in people who you wanted it to do that. And in you, it worked extra good.
Right. Extra.
Yeah, and unfortunately, there's no way to predict that one.
Well, we ordered a copy of her medical records about halfway through this, and we got a stack
I saw the stack, yeah.
God.
about that deep.
Yeah.
And I assume the stack is about that deep now. But, you know, and so each one of the hospitalists that would come in, you know, I get that, they can't read this, you know.
But we do, actually. Well, believe it or not, you can read them pretty quickly, because a lot of it's pretty repetitive.
Okay.
And a lot of that stack is the same page over and over and over again.
But, you know, I get the hospitalist thing, but they're each having to bring themselves up to speed all the time. And it just seemed like there needed to be somebody saying, give them the short version here.
Well,
this is what needs to
You
happen.
know, okay. So that's why we started a patient-centered medical home.
Okay.
And at Billings Clinic, it's actually physically right here. Not across the hall, not at the West Clinic, it's physically here. And all the doctors,
What did you call that again?
patient-centered medical home. So basically what that means is, there's a small group of people that cover each other that are bridging the hospital and here. So there's 2 people that are working full-time in the hospital that are part of our group, and then me and 3 other people are gonna be rotating with them, and that's gonna be the hospital group. And we also, the residency is gonna be, when the residents start, is gonna be here with all of those same people. So if it works the way it's supposed to, you're not gonna be able to escape us. You know, and Dr. Husby and Dr. Cabell and Dr. Klee, who are over there, are gonna be part of that whole thing. So that's something that's been in the works now for 5 years. And we're doing all of the work right now to get it going, and it's gonna start in force in July. That's why I'm here. That's why these new faces you're seeing are here.
Well, I'm glad that's all gonna be taken
Okay.
care of. But more specifically, with everything that's gone on with her,
Sure.
that's one in a bazillion thing, a second opinion that
Okay.
pulls it all together.
So, okay. So I actually went over everything, and Dr. Husby and I talked about this. You know, you're really caught between a rock and a hard place here because of the rheumatoid arthritis.
I know.
And prednisone is, the problem with prednisone is it works.
I know.
And it's interesting, I was fortunate enough, you know, there were originally 7 patients at the Mayo Clinic that got cortisone for rheumatoid arthritis. And the cures were miraculous, they took movies of them. And I was fortunate enough to know one of the 7 before she died, because it was in 1950 that they did this, and I met her several years ago. And there wasn't a single one of those original 7 cortisone patients that were willing to take it after a while.
Really.
Yeah, and I think that's the problem with it, is it works, but you pay this price for it. And, you know, your bones, your weight, the stuff it does to your memory, and so that's why all of these newer medicines were such a godsend, because they take care of the same thing the prednisone does, but they don't do some of those other things.
Right.
Now, I know you've been intolerant, and you've been on 2 of them? 2 of the new biological medicines?
Enbrel.
And just Enbrel.
Just Enbrel, so you never got the second one started?
No, I just did have
'Cause that-
Enbrel and methotrexate.
Okay, yeah,
And
methotrexate is,
meloxicam. That's all I took.
okay, yeah, now meloxicam, that's another issue we can talk about.
Really?
But, so, I had understood that when you didn't tolerate the Enbrel, there was a plan to start you on a different one down the line.
Well, that's what he's talking about, is a different,
A different biological.
not a,
No, I don't know anything about that.
Well, maybe Dr. Husby and the rheumatologist talked about it and you've never heard about
I
it.
might have.
well, the Olivera has said that
There's some.
once she's done with antibiotics and blah, blah, blah,
I'm
that,
ready to see him.
yeah, that
Okay,
there
so
was
that-
gonna, what's the name of it?
There's 10 of them that you can choose.
Okay,
Yeah.
okay.
But they all end in IB,
Right,
just like the Americans. So the prednisone is a really short-term fix here.
I know,
It's just designed to make you feel better over the short haul,
right.
with the idea that you're gonna be on something that's safer, longer acting, more predictable over the longer haul. And it's, I think that's kind of in process, but not clear. So
And
that's,
I think that's what he's just talking about right now for this.
But not a
plan.
biological. He said not a biologic. Olivera has said not a
Today on
biological.
the phone, the nurse said he doesn't want you to put you on a biological. He wants you to either put you on more prednisone, methotrexate, or some drug I've never
okay,
been on.
so Plaquenil,
That might be it.
yeah. Which are all
Sounds like it.
standard, time-honored.
Is methotrexate safe for me to take?
Methotrexate is actually probably one of the, so if you look up methotrexate, a lot of what you read about are the doses that they use for cancer patients,
know.
which are, 10 to 100 times what you'd be taking.
Right,
The kind of doses that people like you are on for methotrexate, as long as you take the other medicines you have to take with it, the folic acid and all that
Right.
stuff, it's very safe over the
yeah, I
long
only took
haul.
6 tabs a week
Yeah. 6 tabs and how many?
of methotrexate. I
Yeah,
don't
but how
remember
many,
what it was.
were they?
Did they probably took it off?
They
by
probably
now.
have
it's
deleted it
gone
all.
now. Were they 1 milligram?
I don't remember.
Okay. A little white pill?
Yeah.
Or a bigger yellow pill?
Oh, they were yellow.
Okay, so you're on 2 milligrams
Yeah,
then, I think.
yellow.
Okay. So that's gonna be the rheumatologist thing.
Right,
So if I look at at the issues that you have, the nice thing about carvedilol, which is actually a very similar medicine to the toprol, is that the great thing about toprol is it lasts for a long time, which didn't do you much good at all. For you, the good thing about carvedilol is that it's short acting, and if you do get a little, it's gonna wear off. Now, of course, the bad part about that is you can't take it once a day. Ideally, you'd take carvedilol 3 times a day. You're only taking it twice a day.
right,
So I think that's a good choice.
okay,
I think planning a transition off the prednisone at some point
right.
is a
And I
really
plan-
good choice.
And I think so too. I've always not wanted to be on prednisone